I'm Heidi, one of the cardiologists at the Ralph. Joined tonight by some of my cardiology team who thought they were going to get away with it, but we've got Emma, our senior cardiology nurse, and our 2 residents, Altin and Sergio, so they'll be able to answer any questions that you might have as well, probably better than me. We're going to talk tonight about interventional cardiology, and the purpose of this evening is obviously not for everybody to come away knowing everything about it, but really just to whet your appetite, explain what it is, what we do, and how we can utilise this to help many of the patients that we see on an everyday basis. So I'm going to start by just a little more general introduction to the concept. So interventional cardiology is one of the subsets of medicine that really lends itself to this concept of One Health. Our patients can't talk, okay? They don't understand our words. They require a caregiver. Parents of any type of baby, animal, just want that assurance that their baby is going to be okay. And there's a very strong psychological, emotional, and a social bond, which is a human-animal bond. So it's very akin to particularly paediatric medicine, but medicine of a variety of kinds. So that's very much an introduction to the One Health concept. So when we talk about One Health, we are talking about the health of people, animals and the environments, which are inextricably linked. And without the health of one, then the health of the other can't really exist efficiently. So people and animals do share many of the same health issues, and that's where we're going to talk about this concept within interventional cardiology. So pediatric medicine and veterinary medicine is particularly key. So One Health is certainly something that we hold very close to our hearts in cardiology. We also have a little bit of a story to tell in our cardiology team as well. So one of our cardiologists, our head of cardiology, Dr. Heidi Ferasin, who some of you may have met, actually worked for a number of years at the University of Minnesota in the USA. And whilst he was there, the university embarked on a One Health project with the local hospital to develop an interventional cardiology device, a device used for the occlusion of patent ductus arteriosus, otherwise known as PDA. So they actually developed a prototype which was originally designed as a prototype in dogs called the canine duct occluder. And you can see on the left the team here working to develop this occluder device, which you can see here in the fluoroscopic image. And it ended up looking a little bit like this. It doesn't look like that anymore. As I said, this was a prototype, but they developed this in a series of dogs to occlude PDA. Now, at the same time, get my mouse working, sorry. This research and development that they produced led to the development of the human device, so the human duct occluder too. So from the canine duct occluder, they went on to develop the human duct occluder for use in predominantly children, but in human medicine. And that then went on to be published and actually is now used in paediatric medicine for occlusion of PDA in children, on small infants and premature babies. So we have obviously quite a keen interest in this One Health concept. And then fate continued to play a part, and you may or may know that actually Luca and I are married, so it's a husband and wife team, and our second child was born with congenital heart disease. We were then in the hospital one day when we were approached by one of the team within the cardiothoracic surgery department. And this is the story that I just want to share with you of my son Mattia.
Tonight to a story of a favour returned in the most incredible way. It involves a heart surgeon who saved the life of a little boy and the surgeon's dog, who was in turn saved by the boy's parents. Confusing, yes, but also remarkable. Sally Williams can explain all.
We start this story at the end, for this is the enduring image of this happy tale. A tale of a doctor, 2 vets, a little boy and a dog. And it all began 4 years ago, the moment Mattia was born.
What happened to your heart when you were a baby? Do you know?
It hurted.
It hurted, did it?
Yeah.
Mattia's hurting heart was in fact extremely dangerous.
It's an emotional time for any parents to welcome a new baby, but when you know that baby has to then face very major surgery with a very high chance of not pulling through. It's an emotional roller coaster.
But thanks to his doctors and the surgery, he did.
And how does it feel now?
Very good.
Does it?
Yeah.
Good heart now, have you?
Yeah, very good too, yeah.
However, in the team who treated him was Dr. Sally, who had his own heart problems with his new baby, Voodoo. But here at St Thomas's, he discovered the incredible coincidence that Mattia's parents not only happened to be vets, but that they also specialise in hearts.
Luca and Heidi offered to scan Voodoo and to see exactly what the heart problem was. So we were surprised first that he had a heart problem. Then, of course, we were surprised that it was so similar to what Mattia had.
And so, whilst you were busy saving their little one, they were busy helping yours.
Well, absolutely.
And so from babies, a bond between Mattia and Voodoo was formed and remains 4 years on.
Hello. He's very friendly. I can see why you like him. Are you giving us all kisses? Does he like giving kisses? Oh.
This is a tale that's seen two little hearts healed and a friendship formed for life. Sally Williams, ITV News, St Thomas's.
No cuter way to finish the night.
So, we obviously, off the back of this, are quite closely linked with St Thomas's Hospital and the paediatric department, which is Evelina Children's Hospital. And we're lucky enough that we have one of the interventional cardiologists that actually is involved with our interventions, some of the more complex cases. And it's absolutely brilliant that we learn from them, but they tell us that they learn from us at the same time. So what is interventional cardiology? It's a minimally invasive catheter-based technique or keyhole technique for the treatment of heart diseases. Its benefit is that it produces minimal scarring and minimal pain, and there's a relatively short post-operative recovery period. The procedures do involve a degree of expertise and also specialised equipment, so they're therefore usually performed at specialised centres, so referral centres in general. Now, the first heart catheterisation was actually performed in 1929 by this gentleman called Werner Forssmann. He put himself under local anaesthesia and inserted a catheter into the vein of his arm, and he didn't know whether the catheter would actually pierce a vein, but he put his own life at risk doing it. He was successful. He managed to pass the catheter into his heart. He completely ignored the department chief who told him he couldn't do it and managed to persuade the operating room nurse to help him. And he actually did that by promising that he would perform the procedure on her rather than on him. What he then did was trick her by restraining her to the operating table and pretended to locally anaesthetise her arm and pretended to cut her arm. And then when she realised he was actually performing it on herself, she started calling for the X-ray department staff to come. So he was successful. He lost his job, but he did win the Nobel Prize in Medicine in 1956. So quite an amazing story, I think. How do we do interventional cardiology? I talked about specialised equipment, and there's a lot of it, as our nursing team will tell you, that needs to be set up in what we call the cath lab, or the catheterisation lab. So a few of the important pieces of kit here, on the left of the screen over here, we've got these, what we call fluoroscopy, or a C-arm. It looks a little bit like a C, so one part of that will go under the table, the other part above the table, and then we have our real-time X-ray beam, effectively, that allows us to visualise what we're doing. And that comes with a viewing screen as well, small viewing screen that the guys here can see, and then a larger viewing screen that we can see at the same time. The next little contraption to the right is something called a pressure injector. That's something that for certain procedures, particularly when we're in the arterial access procedures, we need to inject contrast media at a very fast rate under high pressure. And then this equipment allows us to do that with something we physically can't do by hand. We need a specialised table, which is effectively a radiotransparent table that allows those X-ray beams to pass through, but is also feasible for surgery, so an operating table. Then we're using X-ray, so we need to have lead gowns, thyroid protectors. We use very frequently something called transesophageal echocardiography. So we've got our ultrasound machine with a specialised probe, which is a little bit like an endoscope in a way. It looks like an endoscope, but it's actually an ultrasound probe that's passed down the esophagus and allows us to image the heart from very, very close proximity. And that helps guide many of these techniques. And then finally, we have a defibrillator in the vast majority of these cases, particularly if we're entering the ventricles or the right side usually of the heart. We have pacing pads, so defibrillator pads attached to the patient's chest before we even start. They're hooked up to the life pack, the defibrillator, and in the event that it's necessary, fingers crossed it's not, but in the event we're ready and it's there ready and waiting. So the cath lab, once you've got all that equipment in there, the big room suddenly looks quite small, and there's a load of people in there as well. So this isn't our cath lab, this is another referral centre where you can see that we've got all the equipment I've just talked about, and we have the tables set out very longitudinally, and I'll explain why we do that later on. It's all to do with the types of catheters that we use for the procedure. This is the cath lab at the Ralph, which is in one of the configurations that we sometimes use prior to starting. So we've got all that equipment in there. Imagine having about sometimes 10 people in the room as well at the same time. It gets quite toasty on occasions. So how do we do it? The initial concept is that we need to have access to the vascular system, so a vascular access. And that can be either venous or arterial, dependent on the type of procedure that we're performing. The way that we start this is with what we call a vascular sheath. So we use a technique called a Seldinger technique, and I'm going to explain how we do that. But effectively, we have a setup here with a wire, which is inside a dilator with a sheath over the top, which is then connected here to a side tube with a three-way tap on the end. And bit by bit, we remove components of that to just leave that external sheath within the vessel that we're trying to access. So this little video that I'm going to show you now just explains. So here we've got a needle which we insert through the skin if it's a venous access, or if it's arterial, we make a small cut down into the vessel until we get blood coming back through that needle. Then we pass a guide wire, a soft guide wire, through that needle into the vessel in question. Once that's in place and we're happy it's in place, we keep the guide wire there and we remove the needle over the top, leaving the guide wire in place. Now, over that guide wire, we then pass our catheter sheath with the dilator inside it, over the top and into the vessel in question. And once we're happy that it's in the correct position, we pull out the wire and the dilator from the inside, leaving the sheath in position. And that then allows us to have direct access to that vessel through which we can pass the guide wires and catheters and the equipment that we need to perform the interventional procedure. And you can see here in the image on the right side of the screen that it really is, if we do have to make an incision, very tiny. So for example, access to the femoral artery would require an incision probably a couple of inches long, no more than that. If we're accessing the jugular vein, for example, we often don't even need to make an incision. We do it percutaneously across the skin, and then we just put direct pressure for 20 minutes at the end of the procedure to stop any hemorrhage. So the first approach to the vessel is by something called the mini vascular access kit. So that's a very small gauge needle and dilator and sheath, which is a full French system that we normally use. And we start small, and once we have that wire and initial dilator and sheath in position, we're then able to start swapping for bigger ones, because we need to go bigger and bigger and bigger and bigger to end up eventually with something large enough through which to pass the equipment that we need to do. So we have a whole series of different sizes of dilators, and we start with one over the guide wire. We take it off, we put another one, and then we keep swapping, what we call exchanging, until we're up to the size that we finally require, and then the final size sheath gets passed and left in position. Once that's in position, we then have free access to pass the equipment that we need to access the heart itself. And the first thing that we use for that, usually, is a guide wire. And guide wires come in different types of thicknesses, they come in different types of flexibility, and they have funny different shapes on the end of them, which can be used for various different applications. very soft wires are atraumatic, so they can be passed safely around through the heart without doing damage and without the risk of perforating or tearing structures within the heart. Other guide wires are needed once you're where you need to be in order to support things like the catheters with balloon dilation, etc. And I'll show you how that works later. But very often we use multiple types of wires during any one procedure at different stages during the procedure because we need them for different things. The other piece of kit that is absolutely fundamental is catheters, the cardiac interventional catheters, and there are a whole heap of all sorts of different types, shapes, sizes and functions. So just to give a few examples of some of the common ones we use, from the top left of the screen here we've got something called a pigtail catheter, and the pigtail catheter is an angiographic catheter through which we can inject contrast media directly into the vessel or the heart. And that will then allow us to identify the structure and the anatomy of what we're trying to deal with. And you can see that this particular one has little markers all the way along. They are radio opaque markers that allow us to measure on the screen the exact size of what the equipment we need, for example, and the size of the structures that we are highlighting. On the right-hand side, we've got two other common catheters that we use. The top one is something called a Behrman catheter, which is again a very soft catheter, and it has a little balloon on the end of it that inflates, and that effectively helps it float around the heart under guidance to where it needs to be. And again, it's an angiographic catheter, so these little side holes beneath the balloon allow us to put contrast media through it and inject it into the chambers of the heart to highlight the anatomy. The bottom one here is something called a wedge pressure catheter. That's something that we use when we pass up through the pulmonary artery, and that has a variety of applications as well. But some of these have a hollow lumen that you can pass wires through, others don't, so they have very different applications. So what are the common procedures that we perform from an interventional cardiology perspective? Well, selective angiography certainly is very key. That is purely injecting the contrast media to be able to highlight what we need to see, make correct measurements, identify the anatomy, and choose and select appropriate devices and sizes for the patient in question. Once we've done that, because that's applicable in the vast majority of our interventional cases, the most common techniques we perform would be balloon valvuloplasty, which we can use for pulmonic stenosis and aortic stenosis, transvalvular pulmonic stent angioplasty, otherwise known as a pulmonary artery stent, which we use in some types of pulmonic stenosis. We'll talk about that later. We use ACDO, which is the Anplatz canine duct occluder, which is the follow-on from the prototype I showed you earlier, for the occlusion of patent ductus arteriosus. We also perform pacemaker, permanent pacemaker implantation, and these techniques can be used for pericardiocentesis and fenestration as well. We'll go through those one by one. So selective angiography is for us key. It's applicable in most of the interventional cases that we do, with the exception of pacemaker implantation and the pericardiocentesis and fenestration for pericardial effusion management. But it allows us, as you can see here, to see either the internal chambers of the heart or highlights the blood vessels, and it allows us to determine direction of blood flow as well under fluoroscopic guidance. So we will, at the same time as injecting the contrast medium, record it with fluoroscopy so that we can go back and review that as needed. So this image on the left side of the screen, for example, is a dog that has something called aberrant coronary arteries. So the coronary arteries are the blood vessels, as you know, that supply blood to the heart itself. There we go. And here we can see these are the coronary arteries here, which are running in this particular dog in an abnormal fashion. The post-mortem images on the centre and the right of the screen actually show that abnormality in sadly deceased patient, and they show that the left coronary artery is actually originating from the right side, which is something that really shouldn't be happening. This is very common in certain breeds of dogs, and we'll touch on that in a second. Sometimes when we do an angiography, we actually highlight things we weren't expecting. Sometimes we're looking for one thing, we're performing it for a particular reason, but something else shows up that we weren't anticipating. In this particular two examples that I have here, the left-hand image here is a bulldog with an aberrant coronary artery where those big white arrows are. But we also found that there was another abnormality, which is a common carotid artery. So if we look up here, we have 3 branches. We should normally only have 2. Okay. On the right-hand side of the screen here, we've got a dog in which was having a right ventricular angiogram, and we actually found that this dog had a reverse PDA as well. So we've got here contrast going straight up into the aorta, which is something that we weren't expecting to see. So once we've done our angiography, measurements are key. I did say that we also sometimes use transesophageal echocardiography as well, but very often we do both for security. And that's usually the job of our cardiology nurses here that are very, very skilled in actually acquiring those measurements on the screen and then doing calculations to adjust for the calibration of the device, etc. And from that we can select what size of equipment that we need. So I talked about these radiopaque markers on some of the catheters. You can see that in that top image with the blue tube with those almost metal looking rings. And by measuring the length of those, we can actually work out how big the image is in real life. So let's go through some of the conditions that we can treat with these procedures and talk about how we do it. One of the more common procedures that we perform is management of pulmonic stenosis. Okay. And there are a variety of ways that we can do this. We'll go through them separately. So with pulmonic stenosis, the pulmonary valve usually has 3 parts to the valve, 3 leaflets, and in a stenotic valve, those leaflets are often thickened, sometimes almost stuck together, but the result is that it can end with a narrowed orifice of the valve, so an obstruction to the blood flow, leaving the right ventricle and flowing out through the pulmonic valve to the pulmonary artery and subsequently to the lungs. And like in humans, in veterinary medicine, we have 2 types of pulmonic stenosis. It's categorized as type A or type B. In type A pulmonic stenosis, which is the most common, in our experience, we see this dome-shaped appearance of the valve, and the pulmonary valve leaflets are fused together to agree, and they sort of protrude from their attachment, doming up into the pulmonary artery, a little bit like a windsock. And the size of the pulmonary valve orifice really varies, anything from a pinhole up to sometimes several millimeters in size. But usually it's a central hole, central location, and it can be quite variable in its appearance. So fusion of what we call the commissurae, which is the valve leaflets, systolic doming, and often with this we have something called a post-stenotic dilation. So we have the narrowing and restricted valve, and afterwards the pulmonary artery bulges and becomes very dilated and large. Now in type B pulmonic stenosis, the actual annulus of the valve itself is hypoplastic and underdeveloped and narrowed. And there are often different degrees of thickening of the valve leaflets themselves as well. Usually very little sticking together or fusion of the leaflets or the commissures of the valve. But the valve is often quite immobile and it's not moving as it should do. But generally this doesn't result with a post-stenotic dilation. It is generally just a narrowed artery, if you like, an outflow. And the treatment of this will vary dependent on which of these 2 types we have. I mentioned an aberrant coronary artery earlier as being something that we always check for, always check for it in this condition. And there are a number of breeds in which an aberrant coronary artery is a predisposing finding. So the English bulldog is by far the most common, but I would say in my experience, French bulldogs and any other bulldog type breeds, this is something that we're always very, very hot on as well. But in the literature, we report beagles, Samoyeds, fox terriers, miniature schnauzers, chihuahuas and others. For me, it's the bulldog most of the way. And this is a really interesting fact. So the first balloon valvuloplasty was actually performed in the early 1980s by this gentleman, Professor Buchanan. And it was in 1980, they trialled the procedure in an English bulldog with pulmonic stenosis. and they didn't check for the presence of coronary arteries. They weren't necessarily aware at that point that this was a relatively common finding in this type of breed. They performed the procedure, it was successful, and that then went on to the first BVP being performed in a human, in a child, in 1982. Now, had this dog had aberrant coronary arteries and it not been successful, I doubt they would have performed the BVP in the child 2 years later. But it's just interesting how this has sort of shaped human medicine. We're back to our One Health description again. So for the procedure for a balloon dilation, we use a catheter like this, which is a hollow catheter. We place a wire that goes across the pulmonary outflow tract, over which we place this catheter, and the outside of the catheter at a certain point has a balloon which we can inflate to try and open up that stenotic lesion. So we usually approach these cases either from the jugular vein, from the right side of the neck, the right jugular vein, or in some cases from the right femoral vein, dependent on the size of the heart and various other factors. But the result is the same in that we actually then access the heart into the right atrium of the heart. And from the right atrium, we start by passing a guide wire, usually first a guide wire and then a catheter to measure the pressure in the right side of the heart and perform an angiography. Once we've done that, we finally manage to pass a guide wire followed by a catheter through the right atrium, through the tricuspid valve, around looping in the right ventricle, up through the right ventricular outflow tract towards the pulmonary valve, and then through the pulmonary valve, and then we're able to pass our catheter with the balloon on it to sit so that it is exactly across the valve. So we're coming in here through the right atrium, through the tricuspid valve, into the right ventricle, looping up here into what we call the outflow tract to the right ventricle, where we have our pulmonic valve, and we aim for that catheter with the balloon section on it to sit perfectly halfway across that valve, so that when we inflate it here, we're opening up the narrowing, the stricture of that valve. So this is a video that it's quite fast in some of its progression, so I might pause it and explain to you what's going on. But this is a fluoroscopic series where you can see the different steps of this procedure in a dog with pulmonic stenosis type A. Okay, so we start by passing a catheter through into the right ventricle, and then we inject contrast media, which leaves the heart through the pulmonary artery, through the pulmonic valve, and then goes up to the lungs. And you can see at the level of pretty much where that dark catheter is bending, there's almost like a loss of contrast at that point. That's the level of the stenotic valve. Okay. And once we've identified the positioning of that stenosis, we then proceed to try and catheterize the outflow tract. Here we're passing a catheter with a guide wire that's coming out the end of it, and we're trying to direct this guide wire up through the outflow tract and through the pulmonic valve up into the pulmonary artery. And that can be quite tricky. Sometimes it gets stuck and it doesn't want to go. It's a very, very, very soft wire that doesn't do any damage. And we're aiming to get that to go all the way down into the branches of the pulmonary artery, which is what we've got happen here. We've swapped that now for a slightly stiffer wire. So once we've passed that very, very soft wire, having performed all of these steps, we then need to change that soft wire for a stiff one, because only the stiff one is going to give us the support we need to have that big catheter with the balloon on it in the right place in order to inflate it. So we actually put a different type of catheter over the top, take the soft wire out, and through that then pass a thicker, stiffer wire, which will stay in position. And once that's in the right position, as you'll see in just a second, we then pass the catheter with the balloon on the outside of it over the top, aiming to position the two dots that you can see either side of the valve. And as we then start to inflate that balloon, you can see like a waist, but like an hourglass figure, that's the stenosis, and then it pops open, looking like a sausage as that stenosis is broken down, and the two stuck together bits of the valve are released. We then repeat it to make sure. You can see that went straight up that time without having that hourglass shape at the beginning. So that's a successful dilation. And we usually aim to do this 2 or at least 2, usually 3 times to make sure that we've fully got rid of any stricture that's there. Sometimes in really, really, really big dogs, big Labradors, for example, adult dogs, the balloons don't come in the big enough size to be able to actually do this. They're not wide enough. So sometimes we have to use a technique called a double balloon technique. So we literally do the same procedure twice, simultaneously with 2 catheters and 2 balloons side by side. So when we inflate them, we've got double the dimension, double the diameter to be able to effectively manage the stenosis. Now, the downside of this technique is it's very laborious. You need 2 introducers, so you need 2 sets of access points with 2 catheters and 2 vascular access points and 2 people operating everything, and it's hard to keep them in position and stop those balloons moving alongside each other. So these days we tend to try and use a different type of balloon, which is called a high pressure balloon, which does come in higher sizes. The reason we go for what we call a high pressure balloon is because these standard balloons, when they get very, very big, they burst very easily. You don't need a lot of pressure when you inflate them for them to pop. So we now try and use balloons which are a lot more expensive, but they withstand very high pressures when we're inflating them, but they're really hard to get hold of at the moment, as is most of this interventional stuff in the human sector as well. Now, look at the third trace here. You've got effectively here you'll have a no output, okay, a flat line. This is during inflation, so we lose output. The anaesthetists hate us at this point, and then balloon's deflated and everything starts coming back. So actually for us, although the anaesthetists are on their feet at this point on tenterhooks, for us we're saying, did you lose output, did you lose? And they go, yes, oh phew, brilliant, okay, because that means we were in the right place when we did it. Now, I've just described a standard BVP, balloon valvuloplasty, and that's really only useful for cases of type A pulmonic stenosis, valvular cases where the valve is stuck together. For the cases of type B pulmonic stenosis, the hyperplastic arteries, or sometimes in cases where we have a mixed type, we see that quite frequently where, yes, the valve's a bit stuck together, but also the outflow tract is abnormal. We often need to use a different technique because the ballooning doesn't give long-term results. Often you balloon, it looks fine, but then it all just kind of goes back down to where it was. So those are the cases where we will use a transvalvular pulmonic stent angioplasty or pulmonary arterial stent. Now, they are challenging procedures to perform. I would say the vast majority of these are performed in our bulldog type breeds, particularly Frenchies, I think has been the vast majority of the cases that we've done so far. So this is an angiogram of a dog with a mixed type pulmonic stenosis. So we've got the catheter here through in the right ventricle and pointing up towards the outflow tract, and you can see this kind of irregular shape of the artery. You've got a bit of pinched in and then a little bit of dilation and then another pinched in bit. So this is the sort of case that just a standard balloon alone probably is not going to be sufficient for. So how do we do it? Again, we usually access exactly the same way from either the jugular vein or the femoral artery, usually the jugular vein, and we pass all the equipment in the same fashion to the same place. The difference is, rather than inflating a balloon and taking it away again, we inflate the balloon, which on the outside has a stent, which is an expandable mesh type stent. So when the balloon inflates, the stent inflates with it, and then when we deflate the balloon, the stent stays there to hold open that artery. So there's just a few images here. This is the catheter with the balloon with the stent on top of it, which has been put in the correct position for this dog. You can just make out the dots at either end, top and bottom, and the balloon is in between those 2 dots. The stent is sitting on the outside of that deflated balloon. Then we start to inflate it, and you can see here this is a very, very tight pulmonic stenosis. We've got this massive, what we call waist in the middle. It's inflating at the top and bottom first, and the middle bit will be the last bit to open out. And the stent is inflating, is expanding on top of the balloon. Finally, we fully inflated the balloon. The stent is fully inflated, it's in the correct position, and we then will deflate it and leave the stent in position and remove the balloon from the inside, and then obviously take everything out, and the stent will stay there long term. So I've got a couple of videos here to show you. So this is the inflation of the balloon as it's going up with the stent expanding. The anaesthetist loved us for this one. It was a long inflation. Okay, and we're starting to deflate now. You can see the external covering of that stent there. And then after we've left the stent, we've done another angiography, and we can see now we've lost all that higgledy-piggledy shape of the outflow tract. We've got a nice flow of contrast from the right ventricle all the way through that stent. So that's a successful stent placement. Okay. Now the other application that we don't tend to do ourselves in the cardiology team, but you certainly can do from this approach, is stenting a structure such as the vena cava. This is a video which is courtesy of a cardiology colleague in Italy who is actually a human cardiologist and a paediatric cardiologist and a veterinary cardiologist. And this is a vena cava stenting, so the same approach from probably the jugular vein, but instead of going down into the heart, you just keep going down into the caudal vena cava. Okay. We'll see the stents coming up. And then the stent stays there, and of course everything else gets removed. Now, what do we do if we do have aberrant coronary arteries, if we have our bulldog, for example, or our French bulldog that we've done our selective angiography for, we've checked for the presence of aberrant coronary arteries, and yes, we've found that they are present, as in this case. And in those cases, historically, they would say, don't do it, you can't do it, because if you do, the risk is to either rupture the coronary artery and tear it, which is obviously life-threatening, or to compress it significantly so that you squash the coronary artery and then you have no flow through it, and then you have a huge impact on the heart itself because you stop its blood supply. What we now do instead is something called coronary arterial compression testing. So for this, we need to have an arterial access as well as the venous access to the right side of the heart. And while we have a balloon across the pulmonary artery, we also inject contrast simultaneously through the arterial side so that we can highlight the coronary arteries. And as we inflate the balloon, we check to see at which point of inflation we lose the flow through the coronary arteries. And we know that that's the point we can't go above, because actually at that point we would have a damaging effect on the blood supply to the heart itself. So here we've got access actually from the femoral artery that's then delivering contrast through the aorta to the arterial side. We've got our coronary arteries highlighted, and we can see here with the little arrow we have an aberrant coronary artery that shouldn't look like that. So we then place our balloon across the pulmonary artery from inside the heart, from the right ventricular side, and we start inflating it. You can see about 2/3 of the way down we've got this little notch, which is where the stenotic lesion is. You can also, in the image here, if you look slightly up, there's a little curly structure. That's actually the pigtail catheter for the, from the arterial side behind it, where we're going to give the contrast injection. And then we inflate the balloon and we wait and see at what point we lose the flow. And here, in this case, we did actually lose the flow at a point where there wasn't any point in going ahead with the procedure because it wouldn't have had any benefit for the patient. Now, we can sometimes use BVP, balloon valvuloplasty, for the management of aortic stenosis cases. And again, there are two types of aortic stenosis. We have subaortic stenosis and a valvular type of aortic stenosis. In the subvalvular form, we have the valve, and below that, we have a little fibrous membrane or fibrous ring, which is actually where the obstruction starts. And that's causing obstruction to the flow, leaving the left ventricle and flowing out into the aorta. Now, in other cases, it's valvular, where the valves stuck together, just like in the pulmonic, type A pulmonic stenosis. And the management is slightly different for the two cases. So the valvular pulmonic aortic stenosis can be managed with a balloon, just like we do with the pulmonic stenosis that I've discussed. Unfortunately, the subvalvular lesions don't respond to this very well, and in those cases we end up using what is called a cutting balloon. And the cutting balloon is a balloon that, when you inflate it, has little tiny micro blades on the outside that pop out and actually cut and break down that fibrotic lesion that's causing the subvalvular obstruction. So it's advanced here. As you can see, you've got these little blades which will pop out. And they break down the obstruction. So this technique is used, not particularly commonly, because it's obviously not a technique without risk. There is risk of doing harm, cutting something that you don't want to cut. And so we tend to reserve this technique for cases where they're symptomatic and severe. So if I see a patient with a subaortic stenosis where actually they don't have clinical signs, we'll often not perform this procedure, but we reserve it for those who really are displaying symptoms associated with it. Now, I've got a little video here of a case which did have a cutting balloon procedure for a subvalvular aortic stenosis in a Shih Tzu. This is a quite funky fluoroscopy image showing the obstruction. Here we've got the balloon which has passed across the lesion, and it's very difficult to keep this balloon in the right position because there's such high pressure through the aorta and the left side of the heart. But once it is positioned appropriately and inflated, it's moved very slightly backwards and forwards in order to break down that lesion. And now the obstruction after this is then relieved. Okay. Now, let's go again. Now, valvular cases of aortic stenosis are less common. We do see them. This is a case that we saw in a cat, and we actually performed balloon valvuloplasty in this cat. So the access was arterial from the carotid arteries. It was a surgical access, surgical cut down, I should say, followed by catheterization of the carotid artery. And this video just shows the balloon being advanced. We've got the angiography first of all. We can see that contrast's not really going very far. We've got a severe stenosis. So here we're now going to try and catheterize the aorta across the aortic valve. This is this very, very soft guide wire. In this particular patient, it's tiny because this is a cat. And then we have it in the correct position here. Then we've got the balloon, and you can see how much that balloon's moving, okay? How much it's moving around as we're trying to inflate it and trying to get it in the right position. We inflate this a number of times and then start inflating and realise it's not in the right position, deflate it again, reposition and do it again. But you can see there was a pinched in and it kind of slipped off. So then we have to stop, come back, do it again. So we were successful in the procedure. Inflate again. It's fully inflated, so we deflate. So as I say, we do this a number of times every time we do it, once we're in the right spot. Okay. So you can see how frustrating it can be. Reposition, do it again. Reposition, do it again. then finally, perfect positioning. Okay, you can see that that waste disappeared. And final inflation, no waste. Okay. All right, any questions so far that you want to ask about the BVP? Is it all clear? Yeah, sure.
When you're replacing the balloon, you complete, I guess you're not completely including the aorta,
In this one, the aorta, but if it's pulmonic, then the pulmonary artery. So whichever one you're in, total occlusion, yeah.
And that's fine?
For a short time. Yeah, for a short time. So we use, for the vast majority of the cases, what they call an inflation device, which has a pressure gauge on it as well. And it's a literal manual screw that you push it to a certain point and then you start screwing it for that final inflation, and you can see the pressure gauge. So we only go up to the pre-agreed pressure based on the manufacture of the balloon, so we know what the bursting pressure is. And then once we've reached that pressure, you'll hold it for a few seconds, and then it's a rapid deflation with that device. So you do lose output for, what would you say, 10 seconds? 10, 15 seconds? Something like that. Yeah. The other thing that you can quite frequently see particularly with the pulmonic stenosis is ventricular arrhythmias. That's one of the major complications that we experience. We are ready for them every time because you're inside tickling the right ventricle of the heart, and it often doesn't like it, particularly when you start getting up into that region. So that's why we have the pacing pads on all the time. The anaesthetists are there and ready. They've often got lidocaine either running through a CRI or ready to give. Each anaesthetist has a different preference. But that's quite common, and often when you're doing the procedure you can see the kind of the arrhythmia happening, but they touch wood they can be life-threatening, but that is one of the big things we discuss with carers when we do it, but we take all the precautions, of course. All right? Yeah, sure.
What is the significance of the aortic insufficiency after balloon?
It can be quite significant, which is another reason that we only really reserve it for the really, really severe kind of cases that there isn't another option. There's not a huge amount of follow-up with the cutting balloon techniques either, so I don't think the cardiology community has done many and have followed them long enough to know the success. So it's not a technique that we use. The cutting balloon is not a technique that we use regularly. The balloon technique for the more valvular ones, again, we reserve it for those really, really severe. I mean, that cat was in heart failure, fulminant failure, was back and forth, and there really wasn't anything else we could do. So it was a kind of, absolutely. But yeah, you're absolutely right. It does cause a significant aortic insufficiency, and that's dependent on the already overload situation of the heart, depends on how they'll cope with it. Good question. Well done. Right, let's move on to another condition, so PDA. So PDA, patent ductus arteriosus, we see this again a lot. It's probably the second most common condition I would say that we see. We see it in dogs, we see it in cats as well, quite a lot, more than you would perhaps think. Traditionally, PDA has been managed by open thoracic surgery, so thoracotomy, visualization of the ductus, surgical ligation. That's quite messy, as you can see from the left side of the screen here. It's quite major surgery, routine for our surgeons in a referral setting, but still quite major nevertheless. The patient does need to spend a few days in hospital, chest strains, etc. before going home. So on the right side of the screen, you've got our approach, which is the keyhole, tiny little incision, and the device at the top here sitting to occlude the abnormal vessel. So this is an ACDO, an Amplatz canine duct occluder. So it has a double bell, a nitinol mesh device with a short waist in the middle separating two discs. It has a flat distal disc and then a cupped proximal disc. So basically one of those discs sits in the pulmonary artery side, the waist sits across the kind of the ductus, and the other disc, the other side, sits in the arterial side, so that it can't move either way. And it's very soft and it conforms to the shape of the ductus. over time. And then once you've put it in the right position, you unscrew the cable, the delivery cable that we've used to put it there. So it goes through a catheter. It's contained within a sheath, so within a tube, basically a catheter in the lumen, and then we pop one disc out to position it in the right position, and then we pop the second disc out and put it in the right position. And once we're happy, then we eventually deploy it and unscrew it. So this is just an example of a colleague, Dr. Dominic, who is a Spanish cardiologist working in Italy. That's him performing one of these procedures. You can see how long these catheters are. So that's why we have the operating table, and then we've got all the equipment kind of laid out to the side. And it's always a 2-3 person job because you can't hold it and reach the other end of it and manipulate it on your own. They're using transesophageal echocardiography here. That's generally the resident's job, to be able to guide the procedure and help select the right device size, and then tell us that we're in the right place and that we've achieved occlusion as we like, and when we'll double check that with fluoroscopy as well. So transesophageal echo is done by passing this specialised probe down the esophagus and then overlying the heart, and it has controls like an endoscope to allow it to flex and bend and rotate, and then we can visualise the ductus. So you can see in the centre here we've got the ductus arteriosus, which is the continuous flow in the centre of the screen. And then from these images we can choose our device size. So on the far right we've got a kind of a diagram of how the occluder looks. You can see we've got the two different parts, the flat disc in A side and the wider disc on the B side. And we need the two different measurements of the ostium, so the actual hole, if you like, of the PDA, and the ampulla, which is the fatter part where it widens out afterwards. And we need to know the two different sizes to select what size device is going to fit and stay there afterwards. So this is a really, really intuitive technique and very useful for a number of interventional cardiology techniques. So this is a video of a dog having a PDA occlusion with a amplaps canine duct occluded technique. So we start by passing a catheter from the femoral artery to the aorta, delivering contrast to highlight the ductus. We then go with a soft guide wire, which we pass from the aortic side across the ductus to the pulmonic side. And once that's in position, that allows us to pass the catheter, the delivery catheter, over the top of that wire. So we now have the tip of that in the pulmonary artery above the pulmonic valve. We then deploy the first disc of the device through that. And once that's out, and we can see it out, we pull everything backwards until we find a bit of resistance, and then we carefully pull a little bit more to deploy the second disc, which will end up on the other side, on the aortic side of the ductus. And you can see here how it's deployed, and then it will take its shape and become this sort of dumbbell appearance. Okay? And then we wait, and we wait, and we wait for a few minutes, and we tell a joke. And generally we give a tiny little injection of contrast through the catheter to make sure we're happy. The guys on the transesophageal tell us that they're happy, and then eventually after a little tug and war we release it, and then we do a final angiography and we have no more flow through that ductus anymore. So that's how we occlude our PDA. Now, it's an amazing technique. The downside of it is that you really need a patient that's about 3, and we've done 3 kilos, but really 3.5 kilos, 4 ideally, and upwards in weight, to be able to have an artery, a femoral artery, big enough to pass the catheter that you need through it, because you have to have obviously a certain size wide enough to take the device. And very small patients, sort of 1-2 kilo patients, often will not have arteries which are big enough to facilitate that technique. So then we have to look at alternatives. And the way that we do that is a number of other devices which can have a venous approach rather than an arterial approach. And the veins generally are wider diameters, so it allows us to pass wider catheters and therefore devices of the same size in a patient that otherwise we wouldn't be able to do it. So the first technique that we use is this one called an amplaps, a vascular plug. It looks similar to the ACDO, except it has these 3 components to it. So it has the sort of the central wider part, and then it has the 2 discs on either end. and it's the same diameter, the whole width down, and it's a self-expanding device, which again is made of this nitinol mesh. So this can be deployed from the jugular vein, for example, or the femoral vein, passing through the right ventricle and going retrograde across the PDA from the pulmonic side to the aortic side. And I'll show you a video of how this works. So we've highlighted the PDA here. We've gone the other way. We've gone through it from the pulmonic, right ventricle and pulmonic side. We've positioned our device in the correct place across the ductus, and then we've removed everything. And when we do another little angiography, we'll find that has occluded effectively. Sometimes we have to think outside the box a little bit, and this particular dog, the plug wouldn't stay, it wouldn't fit. We ended up using the Amplatz canine duct occluder upside down. Now, that really isn't a technique that is published, and it's not a technique that we would usually do. The reason that we had to do this was because the screw that attaches onto this with the cable is only on one side, and it's only on the fat side and not the thin side. So you can't choose which way up it goes, which is why it's designed to go from the arterial approach. So in this case, we take the plunge and we've tried it upside down, and we made very sure it was secure and working properly and wasn't going to go anywhere before we released it, and this dog has done absolutely brilliantly. We're now a year on and it's fully occluded with no signs at all. One of the risks of this procedure, of course, is embolization of the device if it's not properly adhered and it whizzes off. I've only seen that in one case, so it's reported, but it's rare, and that dog is equally absolutely fine. But that's the major complication that is reported with this technique. So this is the dog that I've just shown you. This is the transesophageal image. You can see at the beginning we had a lot of turbulent flow, and when we position the device, everything stops. So this is Altin telling me that you're good, okay, this is in the right position, I'm happy. So all this turbulence, place the device, and now everything stops. So complete occlusion. Now, the final technique we can use interventionally for PDA occlusion is this funky little device called a nitocclude PDA. Again, these are human devices that are not designed for use in dogs, but not specifically for dogs, but we extrapolate from the human sector. This device, we actually currently have a paper under review for publication, a case series of using this in, what was the smallest dog, Altin?
1.5 kilos.
1.5 kilos. Okay, so 1.5 kilos up to 4, wasn't it?
And our 14 cases are all less than 3 kilos.
Yeah, okay, so 1.5 to 3 kilos. And this, again, is a venous access, or usually jugular approach through the right ventricle and up. And again, you retrograde, pass through the ductus from the pulmonic side to the aortic side, and then we deploy these coils either side of the ductus to occlude it. So it comes in this special delivery set, this special delivery sheath, and then there is effectively kind of like a push ball on the end that helps you to deploy these coils, and I'll show you some videos of how it works. So we start by doing the angiography, how we normally would, so in this case retrograde, we highlight the ductus, and then we pass through it with the delivery sheath into the aorta. Once we're in the aorta, we then start to deploy the first few rings of the coil, and then we pull it backwards, and we do it the other way around. So we pull it backwards until we find resistance, and when we find resistance, we then start to deploy the remaining coils within and on the other side of the ductus to completely occlude the PDA, and then we let it go and it stays there. And this has been, again, a very successful technique for our extremely small dogs and cats as well. How do we know whether we've been successful in occluding our PDAs? Well, cardiac auscultation is really, really key. Most of these cases have a loud continuous murmur, and when you've occluded it, that goes instantaneously. Some cases you may hear a residual systolic murmur, and very often that's because there's a degree of mitral insufficiency because the heart's big and stretched, and often that will then go as the heart remodels. But the continuous murmur should disappear. Thoracic, transthoracic echocardiography, so standard echo across the chest wall, is really helpful to see whether we have any residual shunt. And I say transthoracic because most of these patients are too small to be able to use the transesophageal approach. And then we also can do the angiography and look at what we call the levo phase. So we're doing an angiography to the right side of the heart. In order to check what's going across the ductus, we need to wait for that contrast to leave the right side of the heart, go up to the lungs, come back to the left side of the heart, and then highlight what we're looking for. So it gets quite diluted as we're doing that, but it can be useful. So just a couple of images here we have of a complete occlusion on the left side. In the centre, we've got this trivial little flicker of colour, which is immediately post-op, but that very often goes and disappears within a couple of weeks to days to weeks post-procedure, because clots form around the devices, and then any residual flow usually completely disappears by the time we see them back for recheck about 2 to 3 months later. Here we've just got a little angiography that's showing us now that this is going to the right side of the heart. It's now coming back to the left side, and we can see that we don't have any flow through the ductus from left to right, because these are left to right shunting PDA. So one of the, so I'm just going back a slide. Okay, yeah. The other applications for interventional cardiology, pacemaker implantation is another very important thing for which we use this technique. Obviously the difference is that the vast majority of the cases I've discussed so far are very often young patients, because they are congenital defects that we're managing. So we either see them when they come for a puppy murmur assessment, or they've been to see their primary vets, picked up a murmur and sent them to us, and we've identified the congenital abnormality. We do sometimes see older patients that it's been either missed, or the carer has not wished to investigate it when they're younger, and then they come to see us and it's more advanced. But pacemaker obviously is a step away from that. That tends to be, as an average age, are older patients who come to see us because of conduction disturbances usually. So there are different types of pacemakers. We can have what we call single chamber and dual chamber. I'll show you both. On the left, we've got a single chamber one. It's just got one port for a lead to connect to it. The middle one is a dual chamber. It's got 2 ports for 2 different leads. And on the right side, we've got this funky little old style computer looking thing, which is called the programmer. So the pacemaker programmer works with radio signal to allow us to actually program the information that we want in the pacemaker device, tell it how fast to beat, what the minimum rate we want it to beat at is, what the maximum rate we want it to beat at, when we want it to kick in, and we can also draw information from the pacemaker and telling us how much battery is left, how much the patient's been relying on the pacemaker, what the activity has been, and therefore what the impedance and the resistance through the lead is, etc. So it's a really key piece of kit. It works with literally, it's like a computer, and then it has a cable, and on the end of the cable it looks like a mouse, computer mouse, and you literally place that over the skin of the patient, overlying where the pacemaker is, and it reads all that information and programs the device accordingly. The 2 little leads that we've got here are 2 different types of leads that we use to actually fix the lead on the inside of the heart. We've got what we call an active lead, which is the one with the little screw on the end, and they are designed to physically be screwed into the myocardium. The other one is a passive lead, and the end of those sort of like prongs on the end are actually really soft and flexible. It's a bit like a fishing kind of line, in that a bit like the barbs on a fishing hook, in that it's designed to get caught up on the inside trabecular of the right ventricle. They're really soft and gentle. We use the passive leads in 99% of our cases. They're safer and easier to use. But we always have the active one just in case it doesn't hold and we physically need to screw something in. So single versus dual chamber pacemakers is really just a description of how many leads and where those leads are going and where they're therefore innervating the heart. So we've got the single chamber, which we most commonly use, which delivers the lead through into the right ventricle, the right ventricular apex. That's where we aim for it to attach. The dual chamber has 2 pacing leads, one in the right atrium and one in the right ventricle, and they just have slightly different implications dependent on the underlying rhythm disturbance that you're dealing with, but generally, as a rule, we use single chamber for 99% of cases these days. So just a sort of an example, so we make a small incision over the right side of the neck of the right jugular vein in order to visualise the jugular vein. Once we have it nice and clean all the fascia off and we can actually isolate that vein, we make a tiny little cut in the vein through which we pass the lead. The lead gets passed down through under fluoroscopic guidance, through the right atrium, through the tricuspid valve and into the right apex of the right ventricle, where we want it to get caught basically and tangled up. And once we're happy that it's then in the right position and it's not going to come off, we then make another little incision just above under the skin in the neck, where we make a pocket, subcutaneous pocket, to fit the actual generator, which is the battery pack, the pulse generator, under the skin. And we make a little tunnelling pocket underneath from one side to the other that we feed the lead through, connect everything up, and then everything is stitched and anchored in position, and the wound's closed and then interrogated and programmed appropriately for that patient. So this is a single chamber pacemaker. You can see just the one lead coming here down into the right ventricular apex. How do we recognise the paced rhythm? So if you look at an ECG of a dog or a cat with a pacemaker, you see these pacing spikes. So I'm just trying to get my mouse to work. These spikes here are what we call pacing spikes, followed by a paced complex here. So here underneath it's actually telling us VP is ventricular paced, and here VS, ventricular sensed. So this is a normal intrinsic beat from that patient. It's doing it on its own, at which point the pacemaker goes, okay, not going to fire, I'm going to wait. And then it might have a pause, and then it says, okay, I need to kick in again, and then it will start pacing again. So here it's sensing, it's waiting, nothing's happening, so it's firing again. So it does depend on the settings of the pacemaker. You can change them, but that's how you would recognise a paced complex compared to a sinus beat. Dual chamber systems, very similar, except you have 2 leads, one in the left atrium, right atrium, and one in the right ventricle, connected to this single pulse generator, which is implanted in the neck in the same place. And then we have again this image on the left where you can see the 2 different leads. And you can see in this top image you've got these 2 pockets, one at the level of the jugular vein, one slightly higher, and the lead is actually tunnelling underneath. So at the end you'll have 2 incisions about that long, one above the other, which normally heal. We just do subcutaneous and subcuticular sutures, and they come back in 14 days for a wound check, pacemaker interrogation. At that point, we change the settings slightly. So when we implant these pacemakers, we normally set them so that they will only go a maximum rate and a fixed rate of, say, 50 beats per minute, 60 beats per minute max. And the reason that we do that is that many of these dogs have had very, very low heartbeats or very long pauses enough to make them symptomatic. And you put a pacemaker in and suddenly they feel amazing, and you don't want them up and charging off and getting really excited, and then that lovely pacemaker lead you've just implanted comes off and out, and then you have to go back and do the whole thing again. So we generally, with our patients, keep them hospitalised for, we say up to 5 days. It very much depends on the patient. If they're very anxious and they're getting really stressed being in hospital, we may send them home sooner. But usually up to 5 days of cage, rest, out to the toilet, back in again, nothing else, hands off, with just standard temperature check, etc. once a day, and check their heart rate. If the heart rate is what we've paced the program at the pacemaker to, we're happy. If it's beating at 50 metronomically, we're happy. Sometimes these dogs have an intrinsic rhythm underneath, so the pacemaker will sit back and wait, and then it will kick in again, so sometimes the rate can be higher. When they come back in 14 days, we reprogram, reinterrogate that pacemaker, check its functions, and turn on something called rate responsive mode. And rate responsive mode allows the pacemaker speed of pacing to change dependent on the physical activity and demand of the patient. So we can set it, for example, to say beat between 60 and 120, dependent on the need for the patient. And we do that when we know everything's fixed and we're happy it's not going to detach. Pericardial effusion is another condition which we can treat with an interventional technique. We don't tend to do it very often, I must be very honest. You can use it both for pericardiocentesis and for pericardial fenestration. And the technique for the fenestration and for the pericardiocentesis is very similar. It's a Seldinger technique we tend to use in the vast majority of our cases, the Seldinger technique where we have a needle through which we pass a wire into the pericardial sac, over which we then remove the needle and pass a catheter, remove the wire, and then we have the catheter in place to perform the pericardiocentesis. And you can buy these as pericardiocentesis sets. They're quite pricey, I think. They used to be about £70 or something a kit, yeah, but they're quite pricey, but you can buy them. But equally in small dogs, they can be quite challenging because they're quite long. The catheters are about that long, so sometimes a sort of a fenestrated catheter does equally well. But what we can do, you can see from this bottom image under fluoroscopic guidance, is with a series of wires and then placing a balloon across the pericardium, across that fenestration, you can actually open that balloon up to effectively make a hole so that then any pericardial fluid which accumulates drains out into the pleural space and is absorbed. We tend to send most of our cases for surgery if they have recurrent pericardial effusions, because it's both diagnostic and therapeutic at the same time, so they can take samples of the pericardial sac, have a good look for the presence or absence of tumours at the same time, and those samples are then sent for histopathology. But it is a technique that can be employed. Right, I have obviously talked a lot about the congenital stuff, more than anything else, and that's where the major part of our interventional cardiology plays out. It's generally the congenital cases. So we put together at the Ralph a little video that we sort of hope will get our families and our carers to understand the importance of getting their puppy's heart murmur or the kitten's heart murmur checked and to have a diagnosis to be able to then identify the problem. And if it's something that can be managed appropriately, we can then pass that information to them and hopefully try and palliate or cure the underlying condition. So this is a little video. If anyone hasn't seen it, I'm going to show it now. It's available on the Ralph website and also on the social media channels. So
vets should have a general health check with a vet when they first join their new family, and at least once a year thereafter. During these checks, the vet will listen to your pet's heart with a stethoscope, which is a tool to amplify the heart's sounds. Through the stethoscope, the beating of a normal heart makes a lub-dub sound, like this. Sometimes your vet may hear a whooshing or swishing sound, usually between the lub and the dub, like this. This sound is called a heart murmur. Heart murmurs are caused by abnormal blood flow through the heart. They can be present at birth, in which case they're called congenital murmurs. Although the majority of heart murmurs are detected in adult dogs and cats having developed later in life. These are known as acquired murmurs. Heart murmurs can be soft and quiet, like this. Or they can be very loud, sometimes accompanied by a buzzing feeling, like this. In general, the loudness of a murmur is associated with the severity of the heart condition, but this is not always the case. Heart problems can affect dogs and cats of any age and sex. Some breeds, however, are more prone to certain heart conditions. And cardiology specialists can advise on available breed-specific screening programs. Sometimes these heart conditions can have life-threatening consequences if not addressed early enough. Some heart murmurs are harmless and don't require treatment, but others may be a sign of a serious heart condition. Regardless of how loud the murmur is, tests are always recommended to identify the cause of the murmur and whether it may affect your pet's health. If your primary care vet picks up on a heart murmur in your dog or cat, they will discuss with you the option of being referred to a cardiology specialist for a full assessment. An accurate diagnosis of a heart condition is based on Doppler echocardiography, which is a non-invasive and sophisticated ultrasound scan to assess your pet's heart. Cardiology specialists are best trained to perform and interpret this test. They can give optimal advice for managing your pet's heart condition. During your referral appointment, the cardiology specialist will physically examine your pet, and they may take a blood pressure reading, which is a valuable part in assessing heart health. For the echocardiography scan, your pet will need to lie still on a comfortable padded table. They may need a couple of shaved patches on their chest to help the ultrasound probes pick up the clearest images of the heart. Sedation is not required in most cases, and instead your pet will be gently held and reassured by cardiology nurses while the scan takes place. The recommended treatment will depend on the type and severity of the condition, and will usually include medical management and follow-up assessments. In some cases, pets may require an interventional cardiac procedure performed under general anaesthesia. These minimally invasive keyhole techniques are performed by a cardiology specialist, using special catheters and guide wires under the guidance of real-time X-rays called fluoroscopy. Interventional cardiac procedures are often carried out to manage serious conditions. Examples include pulmonic stenosis, which is a narrowed heart valve obstructing blood flow to the lungs. This condition can be treated via an inflatable balloon catheter, like in this video. Another example is a patent ductus arteriosus, or PDA for short, which is a persistent fetal blood vessel causing abnormal blood flow between the major arteries. This can be treated by occlusion or the closing of the PDA, like in this video. Once your pet has been assessed and treated by a cardiology specialist, ongoing care and support is provided for as long as your pet needs. If you have any questions or you would like your pet to have a cardiology assessment, please speak to your vet.
So we have these lovely little cards which you're very welcome to take, and they have a little QR code which will link into that video. So if you've got families and carers that want a little bit more information and want to understand a bit more about the murmur that you've just found, that's a really nice way of just giving them a little bit of a basic introduction. We do also do a puppy murmur clinic scheme at the Ralph, which we try and offer very, very heavily discounted echocardiographic assessment. So it's a full echo, the same as for any other patient, but eligible for puppies and kittens who are asymptomatic and less than 6 months of age at the time that they're scanned. And that really is aimed at families who have just acquired a puppy and they've come to you and they've found that, oh my gosh, there's a heart murmur, and obviously what am I going to do? What is it? How important is it? Can we manage it? And that we hope will then be able to give them answers that they and you need to be able to make a decision on how best to proceed, whether that be medical management or whether that be follow-up assessment or an interventional procedure. Or surgery in some cases. So if you want to find out more, just contact us. We're always very happy if anyone with an interest that wants to come and watch. If you want to come along with your patient, you're always very welcome. Just contact us and we can work that one out for you.